Good afternoon, everybody. Good afternoon, respected chairpersons and my dear friends. At the outset, I would like to thank the organizers for giving me this opportunity. So, post-lunch session, Anna. So, request everybody not to sleep off. So, I'll be talking about regenerative interventions in shoulder injury. So, before I start off, I just wanted to find out about the audience. Can those who are doing interventions of the shoulder, USG guided interventions of the shoulder, can you raise your hands? USG guided interventions. How many are doing PRP injections? PRP. Raise your hands, please. On a regular basis, PRP. Prolotherapy. Bone marrow concentrate. Anybody? Raise your hands. Okay. Adipose tissue? Fine, okay. So basically I'll be just talking about superficially about some of the interventions, regenerative interventions that we usually use in the shoulder. So shoulder pain is the third most common musculoskeletal complaint behind back pain and knee pain. So the third most common cause of pain that comes to the hospital is shoulder pain. So rotator cuff disorders are the underlying problems in 65 to 70% of patients with shoulder pain. So the major symptomatic manifestations are chronic shoulder pain, impaired mobility and functional impairments. I'm sure these are all covered by the previous speakers. And these complaints arise due to progressive pathological remodeling of the tendon, leading to increased fibroblast cellularity, neovascularity, thinning and loss of collagen matrix, and fatty infiltration. So rotator cuff tears can be treated non-operatively and operatively. So the current non-surgical standard of care therapies such as physical therapy address the biomechanical and functional deficits but do not regenerate the underlying structural tendon tears. And NSAIDs and modalities and glucocorticoid injections provide symptomatic relief, but they do not prevent the progression of the disease. Moreover, the rotator cuff tears, size and muscle atrophy and fatty infiltration may progress over 5 to 10 years without intervention or surgery. So this is a problem which can progress without an intervention. And surgical treatments such as arthroscopic rotator cuff repairs are aimed at either debriding the tendon or anchoring a torn tendon back to the humeral head. And they do not alter the underlying tendon pathology. So basically the arthroscopic surgeons, what they do is they are debriding the tendon and they are attaching the tendon, but the tendon pathology is not addressed. Incomplete or failed tendon healing occurs in 20 to 25% of patients. So you can see there's a lot of surgical failure also for the shoulder. So 20 to 25% of arthroscopic surgeries have failed tendon healing. So the current treatments for rotator cuff tears are suboptimal and there is a significant need for disease modifying therapies. So I'll start off with the ones that are not commonly done and we should really think of starting off with these things. So mesenchymal stem cells. So although multiple potential sources are existing for stem cells, including placenta and the umbilical cord, most commonly utilized adult sources are the bone marrow and the adipose tissue. So this is due to the ease of obtaining these tissue and also due to the success that these tissues have in producing a large number of mesenchymal stem cells and also their paracrine effects. So what is paracrine effects? So you would have heard of endocrine, autocrine. So basically what paracrine signaling is a signaling from one cell to a nearby cell. So one cell is sending off chemical signals to the nearby cell. So that is called paracrine signaling, whereas endocrine is a cell is signaling a distant cell through the bloodstream. So here in mesenchymal stem cells, the cells that you are injecting will put a paracrine signaling effect to the nearby cell, that is a target cell. So this is a very fascinating image of a stem cell, mesenchymal stem cell. This is a live image, live cell image of a human mesenchymal stem cell. So, bone marrow derived mesenchymal stem cells. So this was the first mesenchymal stem cell that was identified and has been the most extensively studied as well, both in vitro and for therapeutic purposes. Exerts therapeutic effects through their ability to regulate cell proliferation, differentiation, secretes trophic factors and immunomodulatory activity. And bone marrow mesenchymal stem cells are more prone for osteogenic and chondrogenic differentiation compared to the other mesenchymal stem cells. And also it has various other indications in cardiovascular, neurological, musculoskeletal, oncological, rheumatologic and gastroenterological diseases. So this is an image of bone marrow aspirate concentrate. So here you can see the so here you can see this needle that is being used. This is called the Jamshidi needle, and this is, you take the bone marrow from the iliac crest. So here you use the Jamshidi needle to take the bone marrow from the iliac crest, and then you centrifuge. You do a double spin, one spin at around 3200 RPM for 15 minutes, and then you separate out the superficial layer, and then you do a second spin. So what are the components of bone marrow aspiration, bone mac? What are the components? So mesenchymal stem cells are only one of the part of this whole BMAC. It's a very small part of BMAC. Actually there are hematopoietic stem cells, there are platelets, there are WBCs, there are cytokines and endothelial progenital cells in BMAC. Whereas mesenchymal stem cells is a small part of this whole thing. So the function of each of this is different. So mesenchymal stem cells provide regeneration, anti-inflammatory and paracrine effects. Hematopoietic stem cells have immune modulation, tissue regeneration, whereas platelets have growth factors and healing and angiogenesis. WBCs act for inflammatory response and immune modulation, and cytokines are for signaling for the repair and inflammation control. And endothelial progenitor cells have a function for blood vessel repair and angiogenesis. So here I am showing a small video of how bone marrow BMAC is done. So these are the things that are available in the kit. So you can see the Jamshidi needle there, along with the tube for centrifuge. So you need to heparinize all the equipment. Some ACD so that it doesn't clot. So you go into the iliac crest or any other location that you're comfortable with, and you aspirate the bone marrow. You inject it into the tubes. to 25 ml of bone marrow, aspirate, and you need to balance it with another tube of the same weight. So when you're centrifuging, you always need a counterbalance. So you need to make sure that you have some similar, there should not be much weight difference. And it should be kept in the opposite, diagonally opposite, and do this first spin. After the first spin, you need to close the bottom part so that the cells are, the RBCs and the hematopoietic cells are all locked. And then you go for the second spin. So the superficial layer is removed, and then the remaining is shaped to get the bone marrow concentrate. So you can take it out from there and then use it for injecting under ultrasound guidance. It's very similar to PRP. The only difference is that for PRP you take it from the blood vessels, whereas for this you need to take it out from the bone, from the iliac crest. But this has to be a double spin, and also it has the separate tubes and equipment. So that was the bone marrow. So another mesenchymal stem cell that we use is the adipose. So adipose and bone marrow are the most commonly used ones. So this is extensively studied due to the advantageous ability to source the subcutaneous adipose tissue, and this is abundantly found, so you can easily take it. Unlike bone marrow, it is estimated that around 98 to 100% of cells are viable, and also compared to bone marrow, adipose tissue contains 500-fold greater numbers of mesenchymal stem cells. So this is when you see the equivalent amount compared to the bone marrow. And adipose tissue can be harvested enzymatically to yield a stromal vascular fraction, or mechanically to yield a microfragmented adipose tissue. So these are ways of preparing adipose tissue. It can be either stromal vascular fraction or microfragmented adipose tissue. And it is shown that MFAT has a higher concentration of mesenchymal stem cells. But what we have available here is the stromal vascular fraction. So I'll just show you a small video of how stromal vascular fraction of adipose tissue mesenchymal stem cells is prepared. This is microfragmented adipose tissue. So basically, in microfragmented adipose tissue, the adipose tissue is passed through filters which has beads and also shaken. So this is for activating or increasing the amount of regeneration. So I'll just show you a small video about how stromal vascular fraction is prepared.
Step 1. Aspirate 100 to 200 milliliter of fat. Step 2. Transfer the aspirated fat to 50 milliliter syringes and incubate. Post-incubation, we discard the tumescent liquid. Step 3. Pass the fat through nanofilters. Transfer the nanofat into sonostem isolation kit through the safe closed Luer lock port. Step 4. Place the tube into the ultrasonic port till aeroline touches steel part. Step 5. Close the lid and select sample volume and press start. Step 6. As ultrasonic vibration is applied, Nanofat gets further broken down into finer particles for enhanced SVF release. The
So
port also
ultrasonic
rotates
is
90
used,
degrees for
ultrasonic
even spreading
techniques.
of ultrasound to entire adipose tissue. Step 7. Once done, go for the first spin. Step 8. After centrifuged, the cellular pellet settles at the bottom. Collect the cell pellet with the long needle into a 10 milliliter syringe. Step 9. Transfer the cells to another empty tube and fill the tube with normal saline for washing. Step 10. Close the tube, go for second spin.
So the cells are taken and centrifuged again. This is the second spin.
Step 11. Once done, collect the cell pellet at the bottom into a fresh 10 ml syringe. Step 12. Filter the debris from the SVF sample using the polyester filter mesh with a Lure Lock Connect. Stromal vascular fraction is ready to go.
So that's SVF or adipose tissue mesenchymal stem cells. So the commonly used regenerative techniques that we usually all of us are doing are PRP. So PRP is definitely helpful for rotator cuff tendinopathy, and it offers significant pain reduction in around 6 to 7 months, and notable improvements in shoulder pain within 6 months, according to research. And also it's useful for adhesive capsulitis, and it is proven to be more effective than corticosteroids or physiotherapy in managing the adhesive capsulitis at 3 to 6 months post-injection, and also for acromioclavicular joint injections. So the PRP that I do in Pushpagiri is single spin, because it's more affordable and cheaper and easier and faster. So single spin, we use the ACD tube 8 ml, 8.5 ml with the connector to withdraw the blood, and we use a very basic centrifuge machine. And so this is the, so after the centrifugation, we just take off the supernatant and take the buffy coat layer and inject. So that is a single spin, and we usually put it for 3,500 RPM for 15 minutes. That's for single spin. And for double spin, we can use a special tube for collecting 25 ml of blood. And first spin, which goes for 2,000, depending on the centrifuge, the RPM and the timing can be changed. So there are no fixed guidelines as of now. So one of the techniques is 2,400 RPM for 10 minutes, and after the first spin, you lock the lower chamber, and then again go for the next spin. And after the second spin, take off the supernatant and then mix the remaining platelets. So this is the double spin PRP. So this can be injected into your shoulder under ultrasound guidance. So this is PRP. And another very useful regenerative technique is the prolotherapy. So prolotherapy is definitely something that we all need to be doing, because it's very easily available, and thankful to Shashikumar sir for teaching me how to do prolotherapy. And we have been using this in my practice, and we've got very good results. So I'll just show you a small case report which I'm planning to publish soon. So basically, dextrose prolotherapy is injecting hypertonic dextrose into the bony attachments of tendons and ligaments. So it's helpful for rotator cuff injuries, and ranging from tendinosis to partial thickness and small full thickness tears as well. So I just want to show you a case report of a patient who came to us with range of movement restriction and shoulder pain since 4 years. So she was not evaluated. She had a intractable seizure, after which she was not evaluated for why the shoulder pain started, and she had restriction of movement, and then she came to us. We did an x-ray. X-ray showed something like this. So this looked like a malunion with some osteoarthritic changes of both the shoulders, left and right. So then we did an MRI, and the MRI showed as old comminuted fracture of the head and neck of humerus with avascular necrosis of the head and secondary osteoarthritis with chronic partial tears of the supraspinatus, infraspinatus and the subscapularis tendon on both shoulders. So we did prolotherapy, dextrose prolotherapy for her. We did 4 sessions of prolotherapy 1 month apart. So she was with us for almost 4 months. Every month we did 1 session of prolotherapy. And pre-interventions, you can see the range of movement was 60 for flexion. You can see after 4 sessions of prolotherapy, she had almost 110 degrees. And after 1 year, it improved even further. So it's very significant results with dextrose prolotherapy for avascular necrosis of the shoulder, which was this is actually very eye-opening for me, because I never expected prolotherapy to be so effective in avascular necrosis, because the patient had lost hopes. There was nothing remaining. Surgeons were not willing to operate, and she was completely depressed. There was nothing more remaining. So then somehow she got referred to us, and so me and Dr. Betsy from
time is up.
Thank you so much. So this is the post-intervention numerical rating scale as well. You can see the pain has reduced significantly. Thank you.
Thank you.